So the other threat to your psychological health in the CSC world is what is called secondary trauma. There's different definitions out there, but essentially secondary trauma is about the experience of confronting unfixable suffering. So whether that's been someone that's been injured, killed, assaulted, in medical distress, self-harming behavior, it's the unfixable suffering that we bear witness to in the course of our duties out there. And when we're in a helping or protecting role and people are looking to us to help me, fix me, protect me, and we can't, that leads to an experience that we call moral distress, wanting to help but being unable to. The research on moral distress actually started with the nurses in Vietnam, and they were at the MASH units, just like the old 70s TV show. And the helicopters are coming in and the bodies are coming in, and as the nurse does a tracheotomy on this one over here, this one bleeds out. If I fix the bleeding over here, this one chokes out. So how do the nurses cope? They shut down. So this is where this whole notion of compassion fatigue sets in. We stop caring. So compassion fatigue, often a mix of just sheer burnout, overwhelm, frustrations on the job, and that profound exposure to unfixable suffering and the moral distress that causes in us. So I think the exposure to the unfixable suffering, the secondary trauma, is the bigger risk to you in the CSC world, because that's something you're exposed to every day, and I think it has the cumulative build up. So I think there's the risk from the secondary trauma, the moral distress. I think the other type of trauma that's important to talk about for CSC is what's known as vicarious trauma. So vicarious trauma is, we may not literally see the body, but it comes through learning or reading or hearing about the trauma and suffering of others. So I was doing a workshop for a group of CSC staff, including some program people and probation people, and even what they were describing is just in reading the files and the offenses. I remember the one person said, it's like reading a true crime novel. I said, it is reading a true crime novel. And just in the hearing of kind of what's gone on, what people have done, it can really, rip our heart out and sort of take that toll over time and leave us with symptoms where, even though we haven't been the one who's been directly hurt by it or seen it, from what we learn and what we've read, it can deeply affect us, whether that's emotionally, symptoms of PTSD, having dreams or nightmares because of what we've seen. So the secondary trauma, the moral distress, and the vicarious trauma, big risks for you folks out there on the job. So we know that some of the risks to your work and to your psychological health and well-being around the primary trauma, the secondary trauma. And what does that look like? How does that affect us? So we know there's a lot of talk right now about PTSD, post-traumatic stress disorder. There's a lot of us that don't like the D in PTSD. More and more we're learning that these, as in the moment, normal, instinctual, involuntary reactions. We know that trauma can make involuntary changes in the brain and in the body. We know that people with PTSD, their brains are different, their amygdala fires up, Broca's region could be offline, left prefrontal cortex not functioning the same, and if we measure the chemicals in the body, increased rates of adrenaline, cortisol, dopamine, and all those stress hormones, involuntary changes in the body. People that develop PTSD, it's not a moral failing or even a psychological disorder. It's an injury. That's why I really like the military's term, operational stress injury. And it's not just PTSD, it's also other conditions like depression. As a matter of fact, the most common diagnosis following a traumatic event is not PTSD, it's depression. So there's very little research on rates of PTSD in Canadian first responders. We do know police rate 7 to 19%, military about 20%. The study that I've seen in the US with corrections is about 27%. So you guys are at higher rates for PTSD than most first responders. And when we talk about PTSD and depression, what does that look like? 4 key symptoms: numbing, avoidance, hyperarousal, re-experiencing. So after a traumatic event, what is it that we want to numb? Thoughts, feelings. I don't want to talk about it, I don't want to think about it, and I sure as heck don't want to feel it, right? I'd rather feel nothing. So, what's the most common way for staff in CSC to numb? Alcohol. Interesting rates, both with cops and nurses. Rates of alcohol abuse, about 25%, 1 in 4. I haven't seen rates in CSC. I often ask people, is it higher, same, lower? Rarely do I say anyone to say that it's lower. I think alcohol use has pretty much been about the same across most first responder professions in my experience. But it's not just alcohol, so pick it. Anything that will numb us out. I think alcohol is the most common, but prescription drugs, illicit drugs, shopping, gambling, video games, anything that I have to do in order not to think, remember, feel, and numb out, problematic. And I'll tell you what almost concerns me more is people that often later in their career, where they're not numbing through some sort of substance, but so they're sober, they're not addicted, but they're just totally emotionally flat and vacant. It's like nothing moves them anymore. And the risk with numbing is that we can't go that way, be that way at work, and just sort of be stone cold, unmoved by anything, and then go home and be this loving spouse and partner and parent and friend. So when the stuff gets shut down at work, it gets shut down in the other areas of our life as well.